This is Randall Schell, and I'm making a podcast entitled High Yield Subspecialty Review Cardiac Topics, and this is part 2 of a 3-part series. The cardiac keywords from 2015 are shown here. They were reviewed briefly in part 1 of the podcast series. As a reminder, the B stands for the basic exam, the A stands for the advanced exam, and the GAP 2015 refers to the 2 cardiac topics in the 2015 ITE where more than 50% of CA3 residents in the United States missed the question. We'll move right on into our first keyword, which is the CVP waveform. Up at the top, the CVP waveform is shown in its relationship to the electrocardiogram. You can see that there are 3 positive deflections and 2 descents. There's the A, C, and the V wave, which are positive deflections. The A wave is due to atrial contraction and occurs after P wave. The C wave occurs after the QRS complex and is related to the tricuspid valve bulging into the atrium as the ventricle contracts and pushes it upward. And the V wave, as you can see, is at the end of the T on the electrocardiogram, and that V wave is filling of the atrium during systole, at the end of systole. Now, there are things that can occur on the CVP waveform to help us make diagnoses. For example, if we happen to lose the A wave, the patient could be in junctional rhythm, they could be in atrial fibrillation. Giant A waves, as shown by the red star and the figure on the bottom right, can occur when you have AV dissociation. That is, the atria contracting and the ventricle contracting, not in the usual order, but a wave possibly meeting from the atria going down, the ventricle coming up, meeting, and sending this shock wave back up the CVP tracing. A complete AV block would be an example of AV dissociation and giant A waves occurring. They can also occur with V pacing. If you just pace the ventricle and it's not in synchrony with the atria, you can have AV dissociation. And junctional rhythm is an example. For example, after cardiopulmonary bypass, when a patient is reperfusing, not uncommonly they are in a junctional rhythm and have these big A waves on their CVP trace, and when they resume sinus rhythm, the A wave goes away. Things that increase CVP, tamponade physiology, high levels of positive end expiratory pressure, which raise interthoracic pressure, RV ischemia, where the RV is not working very well and pressures build up, and the classic one being hypervolemia. Tamponade and CVP waveform, really this is talking about the concept of diastolic equalization, because the CVP goes up during tamponade, but if you look at the CVP and happen to have a pulmonary artery catheter at the same time, you'll see that all the diastolic pressures across the heart are equalizing. You might want to think of the heart being in a bag of fluid, and that pressure around the heart or inside that bag is transmitted throughout the heart. So the CVP might be 20, the pulmonary artery diastolic pressure 21, the wedge pressure 19, i.e. they're all approximately equal, 20, 20, 20. That's called diastolic equalization and supports tamponade physiology. Constricted pericarditis gives a very unique CVP waveform, as shown over here on the bottom right under C, where you have this square root sign, steep X and Y descents. And when a patient takes an inspiration, when they're not mechanically ventilated but breathing normally, takes an inspiration, intrathoracic pressure rises, the lungs squeeze the bag around the heart, the pericardium, and the CVP actually goes up with inspiration instead of down, and that is Kussmaul's sign. Let's look at the next keyword now, which is fluid responsiveness, stroke volume response to fluid loading. Dynamic parameters have been shown to be superior in predicting what's going to happen when you give someone fluid, i.e. is their cardiac output going to go up, is it going to go down, is it not going to change, rather than just looking at a static parameter such as what's the CVP pressure. For example, if the CVP pressure is 5, Is that suggestive of a high CVP? Well, no, that's relatively low, and you would expect that if you give fluids to that patient, maybe they would respond with a higher CVP, higher cardiac output, higher blood pressure, but you don't know that for sure, and dynamic parameters are better. One of the ways to test whether a patient is going to be fluid responsive and increase their cardiac output stroke volume when you give them fluids is do a passive leg lift, and that's demonstrated in the top a graphic showing a patient initially at baseline slightly head up, and then the back head are put down, the legs are lifted up 45 degrees. It's an auto transfusion basically, and with that passive leg lift, stroke volume, if it goes up and blood pressure goes up, that's a change with this self volume load in a positive direction, and it would predict that if you gave fluids that their stroke volume and blood pressure would go up. So passive leg lift, a dynamic way to test whether someone is going to have a positive response to fluid loading or not. Heart-lung interactions during mechanical ventilation are also used to determine fluid responsiveness. And this is important to realize that this is during mechanical ventilation, which is the most accurate way of looking at this than if someone was spontaneously ventilating not on mechanical ventilation. So it's the heart-lung interactions during positive pressure mechanical ventilation. And we look at pulse pressure variation, we look at stroke volume variation, and we look at changes in the inferior vena cava size during ventilation. The middle graphic shows stroke volume and pulse pressure variation. And you can see that during inspiration, stroke volume goes up. During expiration, stroke volume goes down. During inspiration, pulse pressure goes up. And during expiration, pulse pressure goes down. The bigger the changes that these show of stroke volume and pulse pressure variation with inspiration, expiration, then that would suggest that they are more fluid responsive. If you give them fluids, their stroke volume will go up and their pulse pressure variation will be reduced. Also, if you look at their IVC size during ventilation, normally when you're spontaneously breathing, if you take an inspiration and the negative pressure of the chest, it becomes more negative, blood flow is favored going back into the atria, and there is a drop in IVC size, so it's like the blood's leaving the IVC going into the heart. Inspiration favors return of blood to the heart. And so if you sniff, for example, or take a big negative pressure breath, inspiration, and you're looking at the IVC, for example, on ultrasound, you will see it change and get smaller during inspiration. However, during positive pressure ventilation, if you looked at that IVC and it was huge and dilated and not changing with respiration, you would say, aha, that patient is probably adequately volume resuscitated. That's assuming they don't have tricuspid stenosis, a failing right heart, etc. So fluid responsiveness and stroke volume response to fluid loading can be predicted by the positive passive leg lift test and the heart-lung interactions during mechanical ventilation, specifically pulse pressure variation and stroke volume variation, and also IVC size change during ventilation. So here's a question. The pulmonary capillary wedge pressure would most likely be greater than the actual LVEDP in the left ventricle in which one of the following circumstances? During diastolic dysfunction, LV dysfunction, mitral regurgitation, or aortic stenosis. Now you realize that the PA catheter is sitting in the pulmonary artery, usually in the right pulmonary artery because of increased flow, and when you blow up the balloon on the PA catheter, you're attempting to establish a hydrostatic column of fluid all the way to the left ventricle. Anything between that hydrostatic column of fluid and the actual left ventricle, i.e. mitral valve disease, will change that relationship, and mitral regurgitation would be the answer here. Cardiac physiology, hemodynamic parameters. Let's look at a couple hemodynamic parameters and how they're calculated, and maybe look at a couple clinical points also. Mean arterial pressure is calculated by 2/3 diastolic pressure plus 1/3 systolic pressure. That's one way to do it. And pulse pressure is the difference between the systolic pressure and the diastolic pressure. An example of something that increases pulse pressure would be aortic insufficiency, where you may have a blood pressure of, for example, 140/40 in severe aortic insufficiency, wide pulse pressure. And pulse pressure tends to narrow during hemorrhagic shock, where systolic may be 90, for example, and diastolic might be 75. They're narrowing. Mean pulmonary artery pressure is normally about 10 to 20. When it gets very high, the right ventricle is pumping against a high resistance and the RV can fail. We looked at the CVP waveforms, the positive deflections of A, C, and V, and the descents of X and Y, and what forms those in a previous slide. The CVP is known to not reflect volume status accurately in many patients, and that's why fluid responsiveness tests like pulse pressure variation, stroke volume variation, etc. are used. But especially in patients with LV dysfunction, valvular heart disease, pulmonary hypertension, COPD, pulmonary edema, pulmonary emboli, or tachycardia. In the case of tachycardia, it's like they're not giving enough time for the blood to run off and out of the pulmonary artery, and CVP might not be reflecting what's going on the left side of the heart. So measuring pressures on the right side, CVP, not a great reflection of volume status in what's going on the left side of the heart, and especially in these group of patients. Pulmonary capillary wedge pressure or pulmonary artery occlusion pressure is normally about 5 to 15 millimeters of mercury. We use it as a reflection of preload, and we say that pulmonary capillary wedge pressure is approximately equal to LVEDP if there's no lung disease or valvular heart disease, which then equals left ventricular end diastolic volume, or at least gives us an idea of left ventricular end diastolic volume. So we're using a pressure, pulmonary occlusion pressure, to estimate a volume, and this is fraught with many problems. In some cases, the wedge pressure can be higher than the actual pressure in the left ventricle. For example, anything in between the left ventricle and the PA catheter, such as mitral stenosis, can affect this relationship where they would not be equal. In the case of mitral stenosis, the pressure measured in the pulmonary occlusion pressure could be higher than that in the actual left ventricle because of the valvular stenosis, small orifice, etc. Let's move on to the next key word, systemic vascular resistance and pulmonary vascular resistance calculations. If you realize that flow, represented by Q here, through a tube, our body basically, is dependent upon pressure differential between one end of the tube and the other end of the tube and the resistance in it. And this is simplistically demonstrated by the little diagram I made here, as flow is the difference between P1 minus P2 over resistance R. Now we could take that relationship of Q equals delta P over R and rearrange the equation to solve for resistance, i.e. systemic vascular resistance and pulmonary vascular resistance. Therefore, by rearranging, it would be R is equal to a pressure over a flow. So in the case of calculating systemic vascular resistance, the pressure in that tube at the beginning driving blood into our body, our systemic vasculature, is the mean arterial pressure, and the pressure at the other end of the tube as the blood comes back into the right atrium is CVP. So delta P becomes MAP minus CVP over Q, the total flow, is cardiac output. And then we usually times that by 80 to put it into the proper units. And then PVR is calculated, again, a difference in pressure over a flow. And the difference of pressure in the pulmonary system, the driving force for blood, is the mean pulmonary artery pressure. And the pressure at the other end of the tubing of the pulmonary system, basically, if you like to think of it this way, is the LVEDP, which we estimate by the wedge pressure. So mean arterial pressure in the pulmonary system minus the wedge pressure over cardiac output times 80 is the pulmonary vascular resistance. Now, let's look at a couple other calculations. Cardiac output, simple. That's stroke volume times heart rate. Stroke volume normally is about 60 to 100 mils, and preload, afterload, and contractility determine that. Cardiac index is when you take cardiac output and index it for the body surface area, and this compensates for differences in body size. Ejection fraction is end diastolic volume minus end systolic volume, which is stroke volume, over end diastolic volume, and normally it's greater than 55%. Usually when it's less than 40%, we consider that a poor left ventricle. And we already commented on how to calculate systemic vascular resistance as a delta P, or change in pressure, mean arterial pressure minus CVP over a flow, cardiac output equals a resistance, SVR. Content of oxygen in the blood is that bound to hemoglobin plus that dissolved. And so content is 1.34 mils of oxygen per gram of hemoglobin times the saturation, which should be basically 99% or 100% or 1, plus that dissolved, which is 0.003 times P little AO2. So obviously the content is mainly made up of oxygen bound to hemoglobin, and hemoglobin has one of the biggest effects on content measurements. And it normally is about 20 mils of oxygen per each 100 mils of blood. So in each liter of blood, there's approximately 200 mils of oxygen. DO2 is delivery of oxygen. Delivery of oxygen refers to the content times the cardiac output, or how much flow is going to the tissue times how much oxygen is in the blood that is going to the tissues. So if the cardiac output happened to be 5 liters and the content was the 200 mils per liter of oxygen, that would give us approximately 1,000 mils per minute oxygen delivery. And then VO2 is oxygen used by the tissues, and we classically think of 1 MET, metabolic equivalent, as being approximately 250 mils of oxygen used each minute. Now, that can widely vary depending upon tissue needs. 4 METs is what we think of being when you can climb at least 2 flights of stairs. Let's look at mixed venous now. We're going to look at that in more detail in a couple more slides here. But mixed venous is normally about 70%. Mixed venous comes from the blood that is returning to the heart, specifically when it's in the pulmonary artery before it becomes oxygenated. And the P little O2, PVO2 in this case, is normally 40 millimeters of mercury. So saturation about 70%, millimeters of mercury about 40 only. And there's many things that can affect this global measurement, SVO2, of delivery and tissue oxygen use of oxygen, that is. Cerebral perfusion pressure is calculated by MAP minus ICP, but CPP, when it refers to coronary perfusion pressure, is diastolic blood pressure minus the LVEDP, which we use pulmonary artery occlusion pressure as that number. And the normal range of coronary perfusion pressure is 60 and above usually. Pulmonary vascular resistance, we showed how to calculate that, is a change in pressure over a flow. It's mean pulmonary artery pressure minus the wedge pressure over cardiac output times 80. And pulmonary vascular resistance is normally much less than systemic vascular resistance. In fact, approximately an eighth to a tenth of SVR. The bad things that the cardiologists tell us to avoid when they give us a consult, like hypoxia, avoid it, and hypercarbia, avoid that, and avoid acidosis, those are all things that can raise pulmonary vascular resistance. So if the oxygen levels go down, the CO2 goes up, or the patient's pH drops, or if they get cold, or you give an alpha-1 agonist, which causes vasoconstriction, the PVR can go up. So don't let a patient get cold, acidotic, hypercarbic, or they will vasoconstrict their pulmonary system. The right heart is not going to like that very well, and you may actually end up with right heart failure. There's things that can decrease pulmonary vascular resistance. Inhaled nitric oxide is one. When you inhale nitric oxide, it goes into the alveolus and vasodilates those perialveolar capillaries, binds to hemoglobin, and so it is a selective pulmonary vasodilator, does not dilate the systemic circulation. Vasodilators like nitroglycerin and nitroprusside drop the pulmonary vascular resistance, but also have an effect on the systemic circulation. PD inhibitors or phosphodiesterase inhibitors like milrinone or the erectile dysfunction drug sildenafil or Viagra can also drop pulmonary vascular resistance. Myocardial ischemia detection intraop. What's the best ways to detect it? Well, the most sensitive is a change in wall motion abnormalities detected by transesophageal echocardiography. Now, when ischemia occurs, diastolic relaxation, an energy-dependent process, is affected first, but that's going to occur over a very short period of time. It's going to be difficult to detect, and it's followed very shortly by systolic function abnormalities, that is, wall motion abnormalities like hypokinesis or akinesis on cardiac echo, and then followed by electrocardiographic changes, and then finally hemodynamic changes. So you can see if you're having ECG changes and hemodynamic changes, you're far down the ischemia detection pathway, because the most sensitive is those wall motion abnormalities, such as hypokinesis. Pulmonary catheter isn't a great way to detect myocardial ischemia. If the left ventricle became ischemic and was not functioning well, the pressure may rise in it as it's not working very well. So a rise in wedge pressure. V waves with acute mitral regurgitation can occur, and V waves due to acute mitral regurgitation can be treated by obviously trying to improve myocardial perfusion or blood flow down the coronaries, but also avoiding increases in systemic vascular resistance, which can raise the pressure in the left ventricle during systole, which then can increase the amount of blood that goes backwards through the mitral valve if it's regurgitant, and increase pulmonary artery pressure even more. So the treatment of acute mitral regurgitation from myocardial ischemias: better coronary perfusion, keep the SVR down, and that MR, mitral regurgitation, can be detected by V waves and by the TE color flow Doppler, for example. ECG ST changes are one way to detect myocardial ischemia. Lead 2 and V5 we often monitor intraoperatively, can detect maybe up to about 90% of ischemic episodes. Lead 2 is a good lead to monitor atrial activity and for dysrhythmias, and lead V5 is a great one to look for ischemia. Most MI episodes, however, are silent in the perioperative period, and about half occur without hemodynamic changes. Question: immediately post-bypass surgery, a patient with normal preoperative cardiac function arrives in the intensive care unit with a blood pressure of 108/62 millimeters of mercury, heart rate 85, a cardiac index of 3.4, hemoglobin 9.2, wedge pressure of 14, SpO2 of 99%, and SvO2 of 51%. The most likely etiology of the SvO2 is, first you need to recognize that that's a low SvO2. Remember, normal was approximately 70%. Is it decreased oxygen content? Well, that's not likely because the saturation is 99% and the hemoglobin is 9.2. Is it because of a high cardiac output? Well, that would give you more delivery to the tissues and a higher SvO2. Increased oxygen demand, that's possible. In fact, shivering is a common cause of increased oxygen demand post-cardiac surgery where hypothermia is being used and the patient has not been warmed well, and in the ICU is awakening, neuromuscular blockade is wearing off, they're shivering, they're using more oxygen, and this would be a classic finding. Increased oxygen demand. That leads into the keyword mixed venous oxygenation. Mixed venous oxygenation is a global measure of oxygenation. It is taken from the distal tip of the pulmonary artery catheter. You can take a single sample and send it off for a blood gas, or more commonly you can use continuous measurements of mixed venous oxygenation. The normal numbers are 68 to 77%, and this correlates with a PVO2, or partial pressure venous oxygen, in the pulmonary system, distal tip of the pulmonary catheter, of about 38 to 42 millimeters of mercury. So think 70% and as the saturation, and approximately 40 millimeters of mercury as the PVO2 as being normal. There are many factors affecting mixed venous oxygenation, including cardiac output, oxygen use by the tissues, oxygen content. So some things that can increase mixed venous oxygen. Well, first of all, if your SVO2 was high, it could be due to you're just not using oxygen at the tissue level. Cyanide poisons cytochrome AA3 oxidase in the electron transport chain, and your tissues cannot use oxygen, and so they undergo anaerobic metabolism. The oxygen goes past the tissues, they can't use them, so it just comes right back to the central circulation with an increased SVO2. Cold. If a patient is cold, their tissues decrease the oxygen use approximately 7 to 8% per degree centigrade, and so a low VO2 secondary to hypothermia could cause an increase in SVO2, assuming that delivery stayed the same. If you had a high cardiac output, sepsis is a case of that, where you have a high cardiac output, and you also can have shunting, where blood bypasses tissues, and so the oxygen's not used, it goes back into the venous system and raises the mixed venous oxygen levels. AV fistulas, left to right shunts, severe liver disease, all examples of causes of increasing SVO2 with a high cardiac output. Now, what about decreasing SVO2? Well, if your hemoglobin is very low, that's a common one. If, let's say, your hemoglobin's 4, 5, 6, 7 range, your content obviously is decreased. You may decrease your mixed venous not just because of the content, but because of oxygen use. You're using a lot. If you have a fever, your oxygen use goes up approximately 7 to 8% per degree centigrade. If you happen to be shivering in the postoperative period, the example that we gave earlier, shivering increases oxygen use by the tissues. And if you continue the same delivery but use more, you would then be in a situation where you would have to extract more oxygen from the hemoglobin and have a decreased SVO2. A low SaO2, if the patient's lungs are bad and the blood leaving the heart in the aorta doesn't have a saturation of 97, 98, 99, 100%, let's say it's 85%, well, obviously you have to extract from a starting hemoglobin saturation of 85%. The tissues are going to remove the oxygen, and it's going to come back with a lower SVO2. And then the classic low cardiac output in MI, heart failure, severe hypovolemia. If you're not delivering as much oxygen to the tissues and they continue to use the same, it's going to decrease mixed venous. So let's look at our graphic and go through this step by step. As the blood goes through your lungs and out your heart and out into your aorta, the oxygen content is dependent upon our saturation and our hemoglobin mainly. And our normal cardiac output is somewhere between 4 to 8 liters per minute. We said that content per liter is approximately 200 mils of oxygen. If you had 200 mils of oxygen content and 5 liters going out to the tissue's cardiac output, that would be a total of approximately 1,000 mils per minute of delivery, or DO2. Now the tissues, if they were only using 250 mils a minute, or 1 met approximately, obviously if you're delivering 1,000 and only using 250, there's a lot of oxygen left that comes back to the heart, and the saturation though is approximately 70%. So what do you do if you have a low mixed venous oxygen level? Well, first of all, make sure that you've resuscitated the patient to a mean arterial pressure of 65 or greater, for example, and also make sure that you're oxygenating okay SaO2, that is. So you could look at a blood gas or your SpO2 monitor, your pulse oximeter, and in the case of where your SVO2 is less than 70%, and the problem is your lungs just aren't good and you're not oxygenating your blood very well, for example, your SaO2 is less than 95%, your saturation is 90% on your pulse oximeter. Add oxygen, increase your FiO2, for example, increase the PEEP to try to optimize that portion of our oxygenization. Now, if the SaO2 is okay, SpO2 being a surrogate of it, we can say, aha, our SpO2 is low, but our SaO2 is okay, we better look for another cause. Well, maybe it's cardiac output. We're just not delivering enough cardiac output. So we measure that, and if it's greater than 2.5 liters per minute, that says that's a pretty good cardiac output. So if we have a good cardiac output delivering blood that has a normal SpO2, maybe the hemoglobin isn't high enough, and we should look at that. And if it's low, we'll transfuse the patient. If it's high, we can say, or if it's adequate, then we can say it's not a problem with SaO2, it's not a problem with cardiac output, it's not a problem with hemoglobin. Maybe they're just using a lot with a high VO2 because of pain, anxiety, stress, and we can provide analgesia and sedation. Now, if the cardiac output is low, then you need to say, okay, is it low because their volume isn't adequate? For example, they have a low wedge pressure, or other ways to estimate the volume of the heart, for example, TE and LVEDP, the size of the left ventricle during diastole, or some of those measures that we talked about previously of looking at fluid responsiveness. Give fluids if it's low, and that should increase the cardiac output. But if the wedge pressure is high and the cardiac output's low, then an inotrope would be indicated, and dobutamine would be an example of that. Next key word is systolic versus diastolic dysfunction. Systolic dysfunction is when you have decreased cardiac output unable to meet the demands and low mixed venous saturation. That is, not enough blood going to the tissues. It extracts more from the hemoglobin that it is supplied, and the mixed venous comes back, for example, 45-50%. It would be an example of low global delivery of oxygen and more extraction. Ejection fraction less than 40%, a heart with regional wall motion abnormalities, a high LVEDP, classically greater than 18 millimeters of mercury, are all indicators of systolic dysfunction. So in a preoperative record, if you see EF less than 40%, and if they had a catheterization and their LVEDP is greater than 18, you say, aha, that's evidence of systolic dysfunction, which we normally treat with diuretics, inotropes occasionally, and occasionally vasopressors, as opposed to diastolic dysfunction, which is a relaxation problem and LV compliance problem. And you have high diastolic pressures in the heart. The LVEDP is high, but the ejection fraction, for example, can be preserved. Now, you can have combined, and frequently do, systolic and diastolic dysfunction, but we're talking in the purest sense, diastolic dysfunction. You have high diastolic pressures in the heart, LVEDP, but a preserved ejection fraction. This is classically seen in the patient with long-standing hypertension with LVH, big thick left ventricle, the elderly patient who just doesn't have that heart that relaxes as well. And one of the ways to look at and measure diastolic dysfunction is the Doppler pattern of flow across the mitral valve, the filling of the left ventricle, the classic E and A waves, and also the pulmonary vein systolic and diastolic flow in the pulmonary veins on TEE. We treat diastolic dysfunction by getting at one of the major roots of the problem, which is hypertension, beta blockers, ACE inhibitors, for example, rather than diuretics. Some contraindications to ACE inhibitors are listed here, absolute being a previous angioedema with ACE inhibitors if they have renal artery stenosis and if they're pregnant, while relative contraindications to ACE inhibitors would be where you don't want to drop the SVR in situations like aortic stenosis and hypertrophic cardiomyopathy, where as you drop the SVR, LV outflow tract obstruction increases. These pictures demonstrate diastolic versus systolic dysfunction. First of all, the diastolic or LV hypertrophied heart with diastolic dysfunction is shown here. Big, thick left ventricle. It's like the weightlifter who can't relax their muscles. Huge muscle. Poor relaxation problem or compliance problem, or poor lusitropy or relaxation. As opposed to the systolic dysfunction patient up at the top right, this is the patient with EF of 15%, infarcted left ventricle, thinned out left ventricle. And if you look at their pressure volume curves, the diastolic dysfunction patient is shown on the bottom left, and I put a little arrow here showing where you get LVEDP from. In part 1, we went over flow volume loops, and I hope you remember the point that here is the end of the filling of the left ventricle before it contracts. That's LVEDP. You could trace it over to the y-axis, and you can see that in the case of the diastolic dysfunction patient, LVEDP or diastolic pressures in the heart are high. It's a relaxation problem, as opposed to the systolic dysfunction patient, which has a narrow pressure volume curve. The difference between end diastolic volume and end systolic volume or stroke volume is small, so poor stroke volume. And the heart tends to be pretty big and shifted to the right here. So those are pressure volume curves from a diastolic dysfunction and systolic dysfunction patient. Next key word is effective lusitropic agents on the pressure volume curve. Lusitropy refers to the ability of the myocardium to relax, or diastolic function. Lusitropes that or drugs that are positive lusitropes, that is, beta-adrenergic agonists, milrinone is one of the classic ones. Negative lusitropes, classic would be myocardial ischemia, which the heart does not relax as well in the case of myocardial ischemia, or high calcium levels, another example. So simply, if you look at the bottom right graphic of a pressure volume curve where the red star is, you can see that there is a shift in the pressure volume curve up, such that the LVEDP is elevated because the heart is not relaxing. So at the same volume, the pressure in the heart is higher from here to here, same volume, but pressure is higher right here in a decreased lusitropic heart or reduced relaxation. Cardiac changes with aging, next key word. When a patient ages, their resting heart rate tends to be decreased, and the heart rate that they can obtain with maximal exercise is also decreased and can be estimated by 220 minus age. For example, I'm 55 years old, so 220 minus 55 equals my maximal heart rate should be around 165, and when I ride my spin bike, I can occasionally get up to 170-ish range, but 180s, 190s are no longer attainable like I could do in my 20s and 30s. So maximal attainable heart rate decreased, resting heart rate also decreased. Stroke volume and cardiac output at rest are usually normal and little change from the young, but if you take that patient who's aged and exercise them, they cannot mount the same increase in stroke volume and cardiac output that the younger patient can. They're very dependent upon Starling's law, that is increased filling, and as it fills more, that's the mechanism in an attempt to increase stroke volume and cardiac output in the aged patient. They also have a loss of vascular elasticity such that isolated systolic hypertension is not uncommon. An elderly patient, for example, with a blood pressure of 170 over 85 millimeters of mercury would be an example of isolated systolic hypertension. The elderly patients also have decreased beta receptor responsiveness or sensitivity. This is not a decrease in beta receptor number, it's just that the sensitivity is decreased, and also their baroreceptor sensitivity is decreased. And the body says, aha, what's going on here? I'm not getting as much bang for the buck with the norepinephrine that I have secreted because the beta receptors aren't as responsive. I better mount a bigger norepinephrine response, and so norepinephrine levels go up in the elderly. The risk of coronary artery disease and valvular heart disease with aging and diastolic dysfunction is very common in the elderly, in that classic pattern of an E wave velocity being greater than the A wave velocity on the mitral valve pulse wave Doppler pattern can be flipped such that A becomes greater than E, and this patient becomes very dependent upon their atrial kick, such that an elderly patient with diastolic dysfunction that goes into a junctional rhythm, for example, perioperatively, and loses that atrial contraction and that filling of the left ventricle, topping it up, can become very hypotensive. The cardiac changes with aging also include dilation of the left atrium, and elderly patients are at risk for atrial fibrillation. The left atrium probably dilates, assuming that they don't have mitral valve disease, because of the increase in LVEDP. And as previously mentioned, they're more dependent upon the atrial kick. Which one of the following would be the most useful to determine that heart failure in a patient is caused by diastolic dysfunction rather than systolic dysfunction? Well, you know that it's not blood pressure. Ejection fraction tends to be up in the preserved in the diastolic dysfunction patient, down in the systolic dysfunction patient. LVEDP can be up in both systolic dysfunction and diastolic dysfunction. So we usually tend to look at ejection fraction as one of the measures of the difference, diastolic being preserved while systolic being reduced. Congestive heart failure, next topic. Evidence of decreased LV function is a low ejection fraction, less than 40%, a filling pressure, wedge pressure, pulmonary occlusion pressure, LVEDP, greater than 18 millimeters of mercury, and a cardiac index less than 2 liters per minute per meter squared. Those are classic measures of poor heart or poor LV function. Dyskinesis, wall motion abnormalities. Dyskinesis refers to bulging out of the heart during systole. Instead of moving inward, it moves outward. Hypokinesis is it's not moving inward as much, and akinesis that is being not moving at all. Pathophysiologic changes with congestive heart failure include a lower cardiac output, lower blood pressure, can get pulmonary edema from fluid backing up into the lungs, metabolic acidosis and an increase in lactate from tissue hypoperfusion and anaerobic metabolism. The body tends to retain sodium and retain fluid in an attempt to make that heart work harder and produce a higher cardiac output. They tend to vasoconstrict in an attempt to maintain blood pressure, and the heart rate goes up. Now, all of these things are not good for a patient with congestive heart failure. We don't want them vasoconstricted and retaining all that fluid, so often diuretics and vasodilators like ACE inhibitors are given to patients in CHF. The response to preload of a patient with CHF is shown on the graphic on the right. And in a patient in the blue tracing who has poor systolic function, you give fluids to and you don't get an increase in stroke volume. You'd say, oh, that's not a good ventricle if I gave a bunch of fluid, increase the preload, and we don't get an increase in stroke volume. That's like going over the other side of the Frank-Starling curve. As opposed to a normal systolic function patient in green, you give volume expansion or increase their preload, and look what happens during that volume challenge to their stroke volume. It goes up quite dramatically. One of the gaps in knowledge from several years ago was that beta blockers will actually increase LV and diastolic volume in a failing heart. So if you have a heart that's already failing, giving them a beta blocker can actually make that heart volume go up more. CHF and Frank-Starling curves, specifically, what's the effect of milrinone and phenylephrine is the next key word. Milrinone is a phosphodiesterase inhibitor that increases intracellular cyclic AMP in the myocardial cells, increasing the inotropic state of the heart, causes relaxation of the heart, which is lusitropy, and also decreases both systemic and pulmonary vascular resistance and reduces filling pressures. All of these are good for a failing heart, and inotropy and decreased peripheral resistance is a specific goal that we have in patients with heart failure. while phenylephrine, being an alpha agonist, just raises systemic vascular resistance, and it also constricts the venous capacitance vessels, increasing preload. Both of these are not very good for someone with congestive heart failure. So if you have someone with an EF of 20% and you give them phenylephrine, you make that poor ventricle function against a high resistance, and fluid leave the venous capacitance system and go into the heart and stretch the heart even more. This is not good for CHF. So the bottom graphics, feel free to stop the podcast and look at these in detail if you like, but simplistically they're showing the effect of increased afterload and changes in inotropy on stroke volume and cardiac output. For example, in the bottom left, in the red dots represent points LVEDP on the curves of lower inotropy, normal inotropy, and increased inotropy. So as we increase inotropy at the same LVEDP pressure, we get more bang for the buck and stroke volume goes up. If we increase afterload, make the heart work more against a resistance, the stroke volume goes down. And if we decrease afterload, vasodilate the patient, stroke volume goes up. What are some of the cardiovascular effects of inhaled anesthetics? Graphically, on the right is shown what happens to mean arterial pressure, cardiac index, SVR, and heart rate. Let's look at SVR first. And in the graphics here, you can see desflurane, sevoflurane, isoflurane are vasodilators, and at increased MAC concentrations, the SVR drops. The exception being halothane, which is historical, basically only. So you should think of our modern inhaled anesthetics as vasodilators, decreasing SVR more and more at increasing MAC levels. Now, they decrease mean arterial pressure. And if you look at the top left here, you can see that Sevo, Des, and Iso do it very similarly, and you can't tell the difference between those agents. And they do it mainly by decreasing MAP because cardiac output is maintained. Notice the top right graphic, Des, Sevo, and Iso, with cardiac index being maintained. Again, historically, halothane was terrible in some ways because it reduced cardiac output and cardiac contractility a lot. But our modern inhaled agents, Sevo, Des, and Iso, maintain cardiac output. The heart rate tends to increase in response to the drop in SVR, and if you just measured myocardial contractility in an isolated muscle setup, you would see decreased contractility. But the major point to remember is these inhaled anesthetics vasodilate, maintain cardiac output, and tend to have a reflex increase in heart rate at increasing MAC concentrations. The next topic is electrocardiographic changes with changes in electrolytes. Hypercalcemia is the first one. If your calcium goes up, for example, in a patient with metastatic squamous cell carcinoma, calcium is very high. The QT interval tends to be affected, at least that's what we talk about classically, and the QT interval tends to be shortened. So in the top right graphic, you see an example of hypercalcemia, and the QT interval is very short, as opposed to hypocalcemia, with the classic example being very, very high volume FFP or packed red blood cell transfusion with lots of citrate going into a patient who doesn't have a good liver, i.e. like liver transplant, who you get citrate toxicity occurring, citrate binds calcium, calcium levels drop, and you get this very prolonged QT interval. Potassium tends to affect the T waves, and in the case of hypokalemia, you can see the example of a flattened T wave and the appearance of a U wave. As opposed to hyperkalemia, you get the classic peak T waves. Now, hypermagnesemia, where would that occur? Iatrogenically, it can occur in OB anesthesia situations where magnesium is given to patients with pregnancy-induced hypertension, etc. And as you're giving them magnesium in high doses and get hypermagnesemia, conduction can be decreased, and intervals can be increased on the electrocardiogram. PR interval increases, QRS widens, interventricular conduction delays can occur, and even asystole can occur. And some of these EKG changes can occur at therapeutic levels of magnesium. The next topic is amiodarone. Amiodarone is used to treat many types of dysrhythmias, including supraventricular dysrhythmias and ventricular dysrhythmias. And these are tachydysrhythmias. The classic dose for VTach or VFib that is resistant to defibrillation, you've defibrillated them multiple times, they're still in VTach or VFib, and you will give 300 milligrams IV amiodarone as a bolus to an adult patient. If they have a perfusing rhythm, you can give amiodarone 150 milligrams over 10 minutes. There are some adverse effects of amiodarone. It is a vasodilator because of alpha blocking effects and a negative inotrope because of beta blocking effects. And it does prolong the QT interval, so a patient with torsades de pointes with a prolonged QT interval, amiodarone would not be a great choice. Long-term use of amiodarone has some problems also. Pulmonary fibrosis can occur, deposits in the cornea, which you can see on ophthalmologic exam. Because it contains iodine, it can cause problems with the thyroid, and this includes both hypo or hyperthyroidism. Next key word is treatment of perioperative SVT. We make the diagnosis when there's no P waves and you have a fast ventricular response, and it can be narrow. Classically, that's what we think of, but don't forget that it could be a wide QRS and still be SVT if they had a pre-existing bundle branch block. If the patient is hemodynamically unstable, you're going to go immediately to synchronized cardioversion, but if they're hemodynamically stable, you're going to work to slow the heart rate. If they don't have an accessory conduction pathway like Wolff-Parkinson-White, which we're going to talk about in a couple more slides, which most patients don't, we move immediately to rate control with beta blockers like Esmolol, calcium channel blockers like diltiazem. And if a patient develops atrial fibrillation perioperatively, there's some interesting things that we need to think of. First of all, we got to control the rate so the left ventricle has time to fill. Esmolol can do that. Possible chemical cardioversion with amiodarone. But remember that if atrial fibrillation has been occurring for an extended period of time, or maybe you just don't know how long, you are at risk for having a patient with a clot sitting in that atria that's fibrillating. And then if you convert them rapidly to sinus rhythm and the atria contracts, that clot can pass from the atria, often from the atrial appendage, through the mitral valve, out into the aorta, potentially to the head, and cause a stroke, or go to the other areas of the body. So we need to anticoagulate for 3 weeks prior and 4 weeks following either electrical or chemical cardioversion, unless you perform an echo and show that there's no left atrial or left atrial appendage thrombus present. In the case of a patient who develops perioperative SVT who has pre-existing WPW with accessory pathway, your thought process should go towards getting at that accessory pathway rather than the AV node itself with beta blockers and calcium channel blockers. And in this case, procainamide or amiodarone are drugs of choice. If a patient develops malignant hyperthermia and you are giving them dantrolene, many of them can have dysrhythmias during that time period as potassium levels are changing, etc. Do not combine calcium channel blockers with dantrolene. You can get hyperkalemic arrest, and calcium channel blockers, dantrolene in your mind, you should separate those. Don't give those together. If a wide complex QRS is present and you're not sure if this is VTach or possibly SVT plus aberrancy, i.e. pre-existing bundle branch block, treat it like VTach until proven it's really SVT with aberrancy. Pulseless VTach, how do we treat that? Well, if it's pulseless, obviously it's hemodynamically unstable, and if it's hemodynamically unstable, we must move immediately to electrical treatment. So what are some factors that might affect your ability to defibrillate a patient? It's better to have a large pad size and good contact. If it was dry pads, you're not going to be able to defibrillate well, so lots of gel. A biphasic versus a monophasic waveform. Most defibrillators are now biphasic. Transthoracic impedance can affect our ability to defibrillate. During expiration, when there's not air in the lung, if there's a pneumothorax present, get rid of that pneumothorax and you may be able to defibrillate better. That air between the chest wall and the heart. Previous shocks, giving shock, the second shock has less transthoracic impedance and it may become more effective. And correcting hypoxia and electrolyte disorders can make a favorable effect on your ability to defibrillate. So classically, VTAC, we're going to defibrillate, and if defibrillation doesn't work, as we're doing chest compressions, we are going to give drugs like vasopressin or epinephrine, realizing that vasopressin's benefit is that you can give it once and its dose is not repeated, and it lasts for approximately 20 minutes, while epinephrine's dose has to be repeated every 3 to 5 minutes or so. And giving vasopressin and epinephrine are used during CPR to increase the diastolic blood pressure so that during your chest compressions, your coronaries and your head are perfused better. And then amiodarone can be used if your defibrillation is unsuccessful. The 300 milligram bolus should be given. Repetitive doses of epinephrine every 3 to 5 minutes, and amiodarone can be repeated as needed. And in the specific case of torsades de pointes, don't forget about magnesium. A patient with chronic alcoholism is noted to have the following electrocardiogram in preoperative holding. So before coming back to surgery. The most appropriate therapy in this case would be which of the following? So you look at this EKG and you go, holy mackerel, that's pretty scary. It's coming and going, and it's wide complex, and wow, it's polymorphic, meaning each of the waveforms looks a little bit different. So polymorphic VTAC, that's torsades, and you really should think about magnesium in this case. Let's look at torsades de pointes. Polymorphic, multiple different patterns to the VTAC waveforms, not monomorphic, and that is shown in the top right graphic. Can occur in the presence of a ventricular premature beat when you have a prolonged QT interval and R on T phenomena occurring. Our antiemetics are classic for this. Drugs like phenothiazines, are drugs like droperidol, 5-HT3 inhibitors, dilasitron, ondansetron, tricyclic antidepressants, and there's many other drugs that can do it. Torsades tends to be associated with hypomagnesemia. The alcoholic patient is an example who is often hypophosphatemic and hypomagnesemic and could be at risk for torsades. And the treatment for torsades is if it's unstable and the patient is in this rhythm and not coming out of it. And interestingly, torsades often comes and goes. You'll see it, and then they're back into a prolonged QT interval but a perfusing rhythm. In that case, if they're stable, you can give them magnesium and try to increase their heart rate pharmacologically or paced, because as the heart rate goes up, the QT interval goes down. But if they're unstable, you're going to defibrillate that patient. Lidocaine, procainamide, and amiodarone can all worsen torsades, prolong the QT interval. So think of increasing the heart rate and magnesium replacement as specific therapy for torsades de pointes. Wolff-Parkinson-White is the next topic, and in the graphic at the top right shows a normal patient first with the pattern of SA nodal predominance and then electrical activity spreading through the left atrium, down through the AV node, through the septum, and then spreading out into the heart, as opposed to the WPW patient who the accessory pathway can be present and bridge between the atria and the ventricle, not at the AV node, but the bridge being outside the AV node, can cause lots of problems with dysrhythmias, specifically tachydysrhythmias. So this accessory pathway between the atrium and ventricle is present on electrocardiogram. We can often see the classic delta wave or short PR interval. And here we see a shortened PR interval with that delta wave going up into the QRS complex. The most common form of WPW is antegrade conduction or forward conduction through the normal AV conduction system as shown up here at the top right, and then retrograde conduction from the ventricle to the atria through the accessory pathways. And these can occur very rapidly, and the heart rate can exceed the ability to continue to contract effectively. So normally, even a young person's heart rate up in the 200 range is the maximum, while you can have heart rates over 300 in this situation. So tachydysrhythmias can occur, and if it's hemodynamically unstable, of course you're going to provide electrical energy to get that heart back into rhythm. So synchronized cardioversion can be utilized, synchronizing to the QRS complex. If it's stable, you can consider vagal maneuvers and adenosine and amiodarone and procainamide. Procainamide can work on that accessory pathway, but you're going to avoid, classically anyway, digitalis, verapamil, diltiazem, drugs that work on the AV node, because these drugs can not work on the accessory pathway and actually increase the ventricular response, the rate of the ventricular response. So diltiazem, verapamil, calcium channel blockers, and WPW, think not a great idea. Cardiac pacemakers, last couple slides on pacemakers and ICDs. When we think of a cardiac pacemaker designation, the first three letters are referring to what is paced, atrial, ventricle, or both, what is sensed, atrial, ventricle, or both, and what is the response. Does it shock, do nothing? When I say shock, does it deliver electrical energy, I should say. If you put a magnet over top of the pulse generator of a cardiac pacemaker, many will be converted to an asynchronous mode. Not all, but many. And an asynchronous mode would be ventricularly paced, no sensing, no response to whatever the heart's doing. And so you can see that if that magnet was placed on the generator and it continued to fire at an asynchronous rate, let's say at 70, and the patient could have an R on T and get dysrhythmias. So this is kind of a bailout. If things are going badly and someone has a cardiac pacemaker, magnet can be put on it, and it will usually convert it to a VOO, especially say, for example, they're having interference from electrocautery. A pulmonary catheter, if you put one down a patient, you can see how easily it would be to entangle it in the wires that are in the right atrium or the right ventricle, and you can actually dislodge pacemaker electrodes if they're not there for very long and have not fibrosed in, classically less than 1 month old. Electrocautery dispersion pads in the perioperative period and defibrillation pads should be put far away from the generator. Most new cardiac pacemakers, it's not an absolute contraindication to do an MRI, and also ICDs, but you need to look at the manufacturer and consult with the pacemaker rep if you have any questions. There's no evidence that our anesthetic drugs alter stimulation threshold. We used to worry that succinylcholine can, because of its fasciculation, result in mild potentials that could be interpreted as intrinsic R waves and be sensed by the pacer. This doesn't seem to be a huge problem, and Sux is usually considered safe. There are some factors that can alter the ability of a cardiac pacemaker to work: severe hyperkalemia and hypokalemia, severe hypoxemia, myocardial ischemia, for example, right under the place where the wire is. If it becomes ischemic or infarcted, you may have a pacemaker failure. Some indications for pacemakers: absolute include sick sinus syndrome, a patient who's so bradycardic that they're symptomatic, tachybrady syndromes, atrial fibrillation with sinus node dysfunction and complete heart block, and treatment of prolonged QT syndrome. Cardiac resynchronization therapy, or CRT, with biventricular pacing is becoming more and more common in patients with heart failure. And that is an attempt to resynchronize the heart so that there's good synchrony between the atria and the ventricles to improve cardiac output. And the graphic on the bottom right shows some wires in a patient's heart who is undergoing resynchronization therapy. Usual pacing is RV pacing, so that's shown in 2 here, while biventricular pacing is not only RV and RA, but also LV via a lead that goes in the coronary sinus and is used to pace the left ventricle. So when the slide before we talked about general pacemakers, just usual ones, we're pacing the RV and the RA. Biventricular pacers, not only do we do the RV and the RA, but also the LV via coronary sinus lead. And a strong indication for resynchronizing the heart or doing CRT therapy is the patient with bad heart, ejection fraction very low, less than 35%, and also if they have a wide QRS, that is even better evidence that they will benefit from CRT therapy. If their QRS is less than 150 milliseconds, it's not been shown to be very beneficial. ICDs, pacers, and perioperative management. What do we do if we have a patient such as represented in the top right graphic where they have a dual chamber ICD device, pacemaker that can shock the patient or pace them or both? And usually this is put in patients with severe ventricular dysfunction, someone with an EF of 20% who has recurrent dysrhythmias like VTAC or has undergone resynchronization therapy in an attempt to properly time the atrial ventricle to improve their cardiac output. Usually ICDs are switched off preoperatively. Often a magnet over the ICD generator can do this, and removing the magnet or putting a magnet back on and taking it off. There's multiple different ways to shut on and off ICDs. You need to look at the manufacturer and call the rep if you have any questions at all. Classically, you think of putting a magnet over it, hearing a beep, taking the magnet off, and the ICD is shut off, putting a magnet back on at the end, and hearing the beep again and coming back on. But if you have any doubt, get a pacemaker rep to come, or a pacemaker proficient cardiologist to come and check the pacemaker after surgery and shut it off before surgery. But if that ICD is part of pacing and resynchronization therapy where atrial and ventricle are functioning well and the patient with that low EF is doing well, and you bring them to, let's say, orthopedic surgery, you turn off their ICD pacer, their cardiac output might drop, and you may get into real problems perioperatively. They may go into worsening heart failure. If external defibrillation is required, just don't put the defibrillator pads right over the generator. Get them away from that generator. Transcutaneous pacing, the last topic. If you're really in a bad situation and you need to pace someone, you can slap these pads that are shown in the upper right on a patient and crank up the output and actually pace through the external body surface. Transcutaneous pacing or external pacing can be used to treat bradycardia, complete heart block, although beta-1 agonists such as epinephrine, isoproterenol can be used oftentimes to increase the heart rate in patients with complete heart block. You do not use it to treat asystole. Putting the pads anterior-posterior is usually recommended. You attach the patient to the monitor with these anterior-posterior pads attached to their body. You select their heart rate, the current that you want, and you increase the current until you get mechanical capture, which you often will confirm by feeling the pulse, by A-line, by SpO2 plethysmography, waveform, etc. This is extremely uncomfortable if the patient is awake because it's shocking their chest wall, and they will need sedation usually, or intubation and anesthesia. Short term can be used for stabilization until you can get other means of pacing such as transvenous or epicardial pacers in. There are some synchronized transcutaneous pacing available by newer cardiac defibrillator monitors, but if you're really in a bad state, asynchronous pacing, don't worry about what the patient's actually doing, just put it on asynchronous pacing, crank up the rate, turn up the output, and increase the heart rate. This ends part 2 of 3 podcasts on cardiac anesthesia keyword topics. Don't forget about part 3. Education is not preparation for life. Education is life itself. John Dewey, that's a quote. Hope you have a wonderful day.